Good morning. Thank you, everyone, for joining us today. My name is Bethany Doherty, and I am a program coordinator for OneOp. It is my pleasure to welcome you to today's session on strengthening food security and nutrition readiness in the force. In case you are joining us for the first time, I would like to give a brief tour of our webinar platform so you can find your way around. Hopefully you are currently able to view the slides we are sharing. If you are unable to see them or have any other difficulties, please email us at contact@oneop.org for tech support. As many of you have already done, we look forward to having you join us in the chat pod for conversation and questions today. Several have already shared the location they are joining us from today. Please continue to do that if you'd like. To embed the chat pod so you don't miss any links or conversation, simply place your cursor over the shared slides. You will then see a toolbar pop up across the bottom of your screen. From there, click the chat bubble icon. When typing questions or comments, please be sure to select everyone from the response options drop-down menu so everyone can view them in the chat pod. Please note that the slides and resources are available for download on the event page for today's session. We will be covering continuing education information at the end of the webinar, so please stay tuned at the end if you are interested in continuing education credits or a certificate of attendance. Closed captioning is available for this webinar. You can turn on the subtitles via the Zoom toolbar. If you need to step away from today's webinar at any time, note that a recording will be available for review within 2 business days on the event page. Today's webinar is part of OneOp's Nutrition and Food Security series. An estimated 24% of active duty service members and their families are food insecure. To protect national security and win our nation's wars, warfighters must be food secure, but additionally, they must be optimally fueled to fight. The Nutrition and Food Security series is part of a robust strategy to improve warfighters' physical and economic access to affordable, nutritious food. To view the other webinars in this series, please use the link that is being shared in the chat pod. Thank you for joining us as we continue our partnership with the Defense Department and the U.S. Department of Agriculture to expand the readiness knowledge and networks of the professionals supporting our military service members and their families. The views expressed in this presentation do not necessarily reflect the official policy of the Defense Department, U.S. Department of Agriculture, U.S. government, or OneUp. The mention of any entity or product is for informational purposes only. In today's webinar, you will learn about about 3 food security projects at 3 different military installations: Fort Campbell, Fort Drum, and Fort Bragg. The 4 main learning objectives for this roundtable of presentations are listed on the slide you are currently viewing. There is time reserved for questions following the 3 presentations. We encourage you to ask your questions in the chat pod, and the OneOp team will be monitoring the chat pod and read your questions to the panelists during the Q&A time. I am very pleased to introduce today's presenters. You will hear first from Dr. Benny Choksi and Ms. Dakota Davis from Fort Campbell. Dr. Choksi is an associate professor in the Department of Pediatrics, Division of Military Child and Family Research at Uniformed Services University of Health Science. Ms. Davis is a community health worker at Fort Campbell in the Department of Pediatrics at Uniformed Services University of Health Sciences. The second project will be presented by Captain Kimberly Whitbeck from Fort Drum. Captain Whitbeck is a registered dietitian and chief of nutrition at Guthrie Ambulatory Healthcare Clinic at Fort Drum. And the final project in today's roundtable will be presented by Ms. Whitney Nelson and Mr. Jeremy McCarty from Fort Bragg. Ms. Nelson is a compliance consultant at the Womack Army Medical Center Department of Public Health at Fort Bragg. And Mr. McCarty is the Deputy Director of the Department of Public Health at Fort Bragg's Womack Army Medical Center. And so now I will turn it over to Dr. Choksi to start the webinar.
Good morning, everyone. This is Benny Choksi. We are going to be talking about increasing WIC enrollment in military families at Fort Campbell, which is in Kentucky and borders Kentucky and Tennessee. Thanks everyone for joining us today. We have no conflicts of interest to disclose, and the opinions and assertions expressed here are not the official policy of the Uniformed Services University or of HJF or the Department of Defense. Our objectives today will be to discuss food insecurity just briefly and its incidence among U.S. military-connected individuals, which was already discussed, review prior study related to food insecurity and WIC engagement in military families that our research group has done, and then to discuss the current WIC Chow project that we have at Fort Campbell.
Just to kind of get us started, I was going to touch on a little bit of what is food insecurity. So it is just this economic and social condition of having a limited or uncertain access to food. So you may have food this week, but paycheck runs out and you don't quite have enough to make it through the next week. And then we also a lot of times talk about nutrition insecurity. So we hear families say, we have food in the house, but it might be the 25-cent pack of ramen noodles that have no protein or is not nutritionally dense. So families are missing the nutrition that they need to sustain and go through developmental stages. And like was previously talked about, 1 in 4 service members identified as food insecure. So they were just unable to obtain that quantity or quality of food like we're talking about. And this has some major impacts. So we talk about readiness. We expect these service members to deploy, complete missions, and, their readiness can be affected if they're worried about, are my children being fed at home, or if they're not meeting their nutritional needs, which has effects on behavioral health, family health at home, their ability to, perform to the degree they need to. Retention's always a big conversation. How do we keep people in? And when families are saying, hey, I can't afford to feed my family, I can't afford to feed myself, they may say, this just isn't for me. I'm going to leave the service and I'm going to go on to more of a civilian role somewhere else. And their recruitment, most of our recruiting pool comes from military children. So if they're affected by food insecurity leading to higher rates of obesity, which would make it difficult for them to join, or also if they see their families, struggle financially during their time in, they may be less likely to take that route in the future and not actually enlist themselves.
As mentioned, we just wanted to go over a few themes from our prior study at the Walter Reed National Military Medical Center, first with some quantitative data gathering, and then we also did some focus groups with military service members or their partners or spouses across the country and this information really helped us to understand what interventions might be helpful in terms of decreasing food insecurity potentially, but also leveraging the federal resource of WIC. Dakota will talk a little bit more about what WIC is, but we just wanted to highlight that our prior study helped to confirm for us that WIC is underutilized among military families, and also that military families really deserve some specific attention because they have unique circumstances that are related to WIC and also food insecurity. So we all know that military families move around a lot. Because of that, you can have difficulties engaging longitudinally in resource programs. But of course, we also know there are issues with spousal unemployment related to PCS and other circumstances that might make food insecurity more likely just based on income in the household and other logistical factors. We also wanted to highlight that the federal programs that are available, such as WIC, help military families with increasing the nutritious foods that they might be able to put on the table. And oftentimes there is a stigma as well as misinformation and just lack of knowledge in general that really can complicate food insecurity in military families and can also make it so that engagement with helpful resources may be difficult. And then we'll continue to talk about this, but our focus groups helped us to recognize that the military can really support WIC and other resource engagement really through leadership commitment, education, standardization, and that's another reason why we're so grateful to be here today talking to everyone.
So WIC is a nutritional support program. So it provides nutrition that's specific for different stages of pregnancy, postpartum, breastfeeding women, and then children under the age of 5. So these are all different points in development that, this nutrition is really important. So it can cover pregnant women from the moment they found out they were pregnant. Some states require it to be medically confirmed first. Kentucky and Tennessee are two of those states, so they must get a note from their doctor showing they are pregnant. And then it can go up to 1 year postpartum. So if they're breastfeeding, they'll keep the program for a year. And then if they're not breastfeeding, if they're utilizing formula, they usually keep it for about 6 months. And then children can keep it up until their 5th birthday. And while this program has been around for a long time, over 50 years now, less than 50% of those who are eligible for the program are enrolled. So it's very underutilized, which could be just a lack of knowledge of the program, or we hear a lot of it's only for formula and not realizing just how wide the benefits really are for the program. And so when we talk about military families, there's some nuance to their pay and how it can be calculated. So the USDA allows that certain pays not be included for military families, and this will be up to the clinic to actually put into place. But the two big pays that aren't counted are BH, which is a payment received for a housing allowance, and then any combat-related pay. So if they may be receiving hazardous duty during a deployment, things like that aren't usually counted towards their income because these pays tend to fluctuate for them. And so this makes it where a lot of families are actually qualifying for this program that think they would not be. They say, I was turned away from SNAP, not realizing that, food stamps and SNAP and programs like that have different enrollment requirements than WIC do. And so when we talk about Fort Campbell, if you've never been here, it can be pretty unique. When you're on post, sometimes you're in Kentucky, sometimes you're in Tennessee. Everyone who lives on Fort Campbell is given a Kentucky address, but maybe a Tennessee resident. So this creates this kind of ball of confusion for families when they're trying to figure out, where do I go? Who do I talk to for assistance programs or federal resources like WIC? And so Fort Campbell is a heavily enlisted population. It's a combat heavy base. So we have a lot of younger service members. We have the 101st, then we're going to have 5th Group and 160th here. Rapid deployments, they're pretty much coming and going pretty often. And then when we look at the income for Fort Campbell, the median household income was around $45,000. And then we have a very large young population. So 16.3% of the people living on Fort Campbell were under the age of 5, which kind of fits into that WIC category. And just kind of drive that home, Blanchfield, which is our hospital here on post, in 2024 delivered over 1,300 babies. And that's not including the military children being born out in the civilian hospitals or clinics in the surrounding areas like Vanderbilt or Tenova and places like that. And so this is kind of where our project started at, and what we wanted to look at was, how do we increase enrollment, but also how do we maintain their enrollment? We see a lot with WIC that many families, by the time the child is done with formula, they no longer stay in the program and they leave it pretty early and are missing out on some of the nutrition benefits that they could be receiving. So we really want to work towards those two things.
So to meet the first objective of enrollment, we really wanted to do targeted outreach. And in order to do that, within our research division in the Military Child and Family Research Division at the Uniformed Services University, we had created a data sharing agreement with the Defense Health Agency. And what we essentially did was query the military data repository and the DEERS system to extract data based on first location. We wanted service members at Fort Campbell. And then we also included information based on their rank, which gives us a surrogate, idea of their pay, years in service, and also the number of dependents that they might have, because we used all of this information to then create a list of potentially eligible for WIC service members at Fort Campbell. And then we had community health workers, of which Miss Davis was one, perform targeted outreach with mailer and phone to further explore if that military family could be eligible for WIC, and if so, assist with WIC enrollment. We had a lot of support from Fort Campbell in order to do this. We met with both the base commander and also the hospital commander when we sent letters out to the service members to let them know that their families may be eligible for the WIC program. The hospital commander actually had his signature on those letters, which really helped us to decrease some of the stigma that we had previously mentioned can be associated with resource engagement. And we continue to have really great relationships with others at Fort Campbell that have really helped us to be able to be successful in this work.
And to continue that enrollment piece, we knew that we needed to do more than just the letters sent out. So we knew that there were going to be families getting missed when we were doing our data pools because they weren't happening every month. So, and then you typically see families rolling in pretty often. We have a pretty high turnover of in and out of service members. So we were like, where can we connect with these families additionally? So we created flyers and brochures that were military specific. So it, had information specific for military families. It had families that looked like them on it. So that way, when they would see the messaging, they'd realize like, oh, this is something that a military family can utilize. So it just highlighted the benefits of WIC, and then it gave them a way to contact me. So they could reach out, we could go over what to expect from the program, and then look at their eligibility. And so, we really worked heavily with the medical clinics to do this. Army Community Services and then Parent Central Services were some big areas that we targeted. And then with this, I was able to do some clinic outreach. So I was based out of the Women's Health Clinic, which is where we see all of the OB appointments coming through. And so we'll talk about that a little bit further, but being able to actually have someone in a position where they could come in, talk face to face, see somebody, and just, get that information was really helpful. And then we continue to do a lot of presentations and just talking to families and, here's a resource, here's how it can be helpful, and here's how to connect with it. And through that, I was briefing once a week to all the incoming service members, whether they, had young children already, they were planning to in the future, or if they were in a leadership position. I would always tell them, this is a good program to have the information in your back pocket, because you may meet someone that could use it, or in the future you could utilize it as well. And through that, we've had almost 5,000 attendees in 2024 at that orientation. And, this is kind of an overview of how our screenings went in clinic. So this were not from our letters we sent out. These were just people walking into the clinic or calling into the clinic looking for the service. And it started out kind of slow. People had to figure out where we were at. Staff had to get comfortable with us to know, we're here and you can connect families. So you kind of see that slowly grow over time. If you're familiar with military, they tend to take 2 big points of leave where they will leave the base one time in the summer for about 2 weeks. And then again, something called holiday block leave in that December, early January timeframe. So we did see drops at those times of screenings. But in just the January and February 2 months, we saw 106 screenings, and 100 of those were individuals who just found out they were pregnant and were screened in our Women's Health Clinic. And this is how our in-person screening went. So we saw between December 2023 and February 2025, as we started to pick up 441 screenings. 66% of those families were eligible for the program. And these were families who were not already engaged in the program and, really needed that information and talked to about, here's a good resource and how to utilize it. We do have to refer to 2 different states because, like we talked about, there's that divide here at Fort Campbell where you might be in Kentucky or you might be in Tennessee. So we sent 115 of those to the Christian County Health Department, which is our closest clinic for Kentucky. And then we sent 176 to Montgomery County, which is our closest Tennessee clinic. As far as our in-clinic screenings, this is kind of an image of what it looks like as far as rank eligibility, because that's a question we get a lot of, who is this program for? Is it only for, the young privates, the E2, E3 kind of age range or rank range for families? And, as it does become less likely that the higher your rank is, that you're eligible, there are still those who are of higher rank that are eligible, just depending on their family size. One area we see struggle with eligibility, though, is our dual military families. So they're both enlisted, they're both serving. They tend to have a harder time getting enrolled into the program. And then we do see a lot of our E4s, E5s, a lot of our retired families, and then we do, see minors who come through the clinic who are dependents of service members who are currently experiencing a pregnancy who qualify for the program. But when you're talking about eligibility, there's things to consider: household size, their years in service, and if there's a second income, because those are all going to affect whether they are eligible. And then we looked at, if they had a second income, how likely were they to be still eligible for the program? And we found out of those that we screened, only 56 families had a second income, and only 14% of those were eligible for the program.
So we just wanted to go back to our original objectives. The first one was to increase engagement, screening and engagement in the WIC program for military families at Campbell. And we did that in two ways, both as we had originally intended through the letters and the mailers, and then also by in phone. But then we also wanted to work on retention. How do we collaborate with local WIC offices to make sure that families continue to stay engaged in WIC? Because the research really shows that families after their children turn 1 year of age don't need formula anymore, often fall off from their engagement. And for military families, of course, there's the relocations and other issues that can lead them to not engage in the program long term. What we ultimately found was that it was difficult to create these partnerships. While we had a great relationship with the local WIC offices in Tennessee and Kentucky, there are just federal regulations, state regulations that make it difficult to, overcome some of those logistical barriers. But what we were able to do was really leverage the Genesis portal and make sure that families knew that they could pull up their Genesis portal on their phone to use anthropometric data that was already gathered in clinic, or you could pull up a positive pregnancy test to show, your medical confirmation of pregnancy. And this was at least one small way in which we could help families navigate some of the logistical barriers that may prevent them from engaging in WIC. This is just here a flow chart of what we had originally set out to do. So Dakota spent some time talking about the in-clinic screenings, which was truly an added bonus of our 18-month project. We did not recognize that we would have that success. And we wanted to focus on that because we do think that that in-person interaction is so useful. But we wanted to just give a quick update on, what happened with all those mailers we sent out and the phone calls that we made to individual people. And just going over this slide quickly, we had approximately 5,000 people who were determined to be highly likely to be eligible. Of those, we connected with 38. Of those, we connected with about 1,400 people, and that's about 38%. And of those that were screened, 1,000 of them were eligible. So 3/4 of the people who we were able to get in touch with and screen using a military specific WIC screening tool that we'll go over in just a minute were eligible for services. And of those people, 1/3 of them had to be referred to the program by us because they did not know that they were eligible. And so we just want to highlight that here, that as you continue to go down this flow chart, you recognize that one, there are many military families who can be eligible for the WIC program, and also 1/3 of people here were eligible for the program and did not recognize that they were eligible, and therefore they were unenrolled.
So when we talk about doing a screening in clinic, this is the tool we utilized. A member of our team created. It's a basic Excel spreadsheet that has the built-in WIC income guidelines. So based on how many people are in your household, how much you can make monthly to qualify for the program. And it also has the military pay scale built in. And so we would update this typically twice a year because military families tend to see a slight pay raise in January. And then June, July timeframe, new WIC guidelines are released for how much you can make to still qualify for the program. And so it would take, 3 basic pieces of information really to get an answer for a family. How many people are in the household? How many economic units using the WIC guidelines? So this could be an active pregnancy, children in the home, the parents in the home, the service member, regardless of whether they're deployed, out for training, they're still counted in that household total. And then if they have extended family living with them that they care for, they're included in that. And that would pull down how much they can make a month to qualify for the program. We would then put in their rank and their years in service, because that's what shows how much a service member will make. So an E5 in the over 6 category. So this is someone who has about 6 to 7 years of service, because at 8 they would receive a pay raise again. It looks at their BAS and their basic pay. BAS is a entitlement that families get. It's for the service member themselves for food. So these are for families who are not eating in the DFAC or the dining facilities provided by the military. And then their base pay is just the pay that they receive because of their rank. Gives you the total and gave us an answer of eligible or not eligible. And all this had to be confirmed still at the local WIC clinics, because I was not able to actually enroll in family. I was just able to let them know you potentially are and connect them. And then we look at it again, and this kind of shows the highlight of single service members, and they are, at a higher risk of financial strain. They have higher expenses when it comes to childcare and things like that, because they don't have someone in the home to help care for the child. But most of the time they did not qualify for the program because for their family size, it was too small compared to their income. So we see an E3 with just 3 years of service not qualifying for the program by $100.
All right, so I know that we are over our time. Sorry about that. So I'm just going to go just quickly over our takeaways here. We presented to you a lot of information, and just to highlight the main takeaways, the first is that WIC is underutilized among military families, and it can be an extraordinarily beneficial resource. We have calculated that it can increase the family's income for food by $100 to $200 a month, depending on the age of your children, how many children, and where you live. We showed you that we were able to utilize DEERS and create a list of families who are highly likely to be eligible for WIC, and then do targeted outreach. We have found actually that process is really quite labor intensive, and what Dakota has been doing in the clinics, and I saw the question in the chat, when we refer to Dakota being in the clinics, that's the Women's Health Clinic at Blanchfield, and she also had referrals from the pediatric clinics. The WIC clinics are off base, but we did have partnerships with those individuals as well. But we have found that in-person screening and in-person connection has also been very useful and required less of a time commitment up front. And this WIC eligibility tool that we have is a really easy to use Excel spreadsheet. And our biggest next step from this work is to figure out how to disseminate this eligibility tool to other individuals so that they can use it, or other programs. And we are trying to see if we can get that on a website. And so those are, some of our summary of what we just presented. And then the takeaways are really that there are misconceptions about WIC eligibility that impact participation. The biggest is often about the basic allowance for housing. And then there's also a need for universal policies in terms of eligibility, screening, and documentation. And also there's just a need for outreach among military families. And so I think all of us on this call can do our part in making sure that military families feel supported, and they recognize that there are resources available to them at no extra cost. Thank you all.
Good morning, everybody. So I am Captain Kimberly Whitbeck up here at Fort Drum, New York. So today I'm going to discuss development of a food security working group and a food resource guide that we developed here at Fort Drum. This is just my standard disclaimer. And so really where all of our efforts up here in the last 2 to 3 years at Fort Drum began with our Health Disparities Council that they run here at our MEDAC, or our medical department activity. Essentially here it is an outpatient clinic. We do not have any inpatient or hospital services. But myself and my counterpart, Lisa Prue, attended these quarterly meetings And it basically just helped to identify disparities under the Joint Commission that could be addressed through improvement of our health registry metrics. So we were able to help this council identify a health-related social need, which we came together and agreed upon food insecurity. And this was back in October of 2023. So from that point, we basically created a standard operating procedure with our chief of ambulatory nursing and our deputy chief of clinical services that outlined this health-related social need as food insecurity. And it then outlined making it a requirement for all of our primary care clinics, behavioral health, and our OBGYN clinics to screen for food insecurity for all patient encounters within our MHS Genesis record. The SOP also outlined a need for an established working group, which I'll discuss on future slides, for Lisa and I to provide quarterly updates to our performance improvement team to track any metrics, as well as yearly Joint Commission inspections to evaluate any progress made. So you can see here on the screen on the right, that snapshot is what the food insecurity screening looks like in our medical health record. And we use this 2-question screener and provided in service to all of our clinics as well as to why they should be completing the screening, why they should be completing it every encounter as possible. As previously discussed, we know that someone's food security status can change. So even if it's a month apart visit, right, they could have some hardships that would equate to causing a positive screening. So it just provides these 2 questions to them where they can answer often or sometimes true. So whether within the past 12 months, you worried whether your food would run out before you got money to buy more, or within the past 12 months, the food that you bought, sorry, trying to move a screen here. Within the past 12 months, the food you bought just did not last you and you did not have the money to go buy more. So what we instructed all of our clinics to do is if someone answered often true or sometimes true, they were required to provide these patients with the food resource guide that we developed, and I'll go into more detail on that later. And they also were required to submit a medical referral to our nutrition clinic, where myself included, there's 2 of us dietitians who would help address that and get the patient signed up for any applicable services and go through some of those resources with them one-on-one. So Lisa, my counterpart, and I intended to make this more than just a check the box requirement in order to fill Joint Commission standards. So instead of simply completing the screening tools and handing out the resource guide, we really wanted to pour efforts into a working group as well to assist our Fort Drum community in a more meaningful way. I will mention that we originally planned to rely on the food security screening tool as our primary metric. We anticipated and have found several limitations that have caused us to refer to and develop different avenues for obtaining metrics. One of these being that we perceive there is often stigma associated with soldiers and or their family members coming forward for help in general. But especially we were finding that during nutrition appointments with us in clinic, where even though they filled out a positive screener and may have directly been notified that there was a referral placed, we often find that these patients or family members are no-showing their appointments with us, despite reminder calls that we make and an explanation provided by our scheduling assistant. So along the way, we have therefore collected metrics on local food pantries, the CAPC mobile food pantry that I'll discuss in detail, and our local WIC to provide an idea of the need in our community. And I will just be honest and transparent that we are continuing to work on our metrics going forward. We're continuing to work on getting our Garrison Installation Prevention Advisory Group and Army Public Health Nursing to expand and share results of their Community Needs Assessment Surveys, or CNAs. And when I describe some of our specific initiatives, I will discuss our ways or ideas for a way forward to track these metrics. So with the development of a working group, myself and Lisa started our working group very small after this SOP was created in October of 2023. So our intent was to ensure that the quality of care exceeded Joint Commission standards. And we started very small within our medical community, inviting our social workers, behavioral health teams, our medical chaplain, public health nursing, and other counterparts that wanted to be involved. And then we had expanded from there. So in the beginning, we had started with about a quarterly meeting as we were trying to develop relationships and bring in more groups for resource sharing and development of further food resources. But we are now at a point where we're holding monthly working group meetings to expand and develop new food resources, update our food resource guide that I'll talk about. And we have continued to gradually grow our working group. So in the next slide, I'll kind of touch on all the stakeholders that we currently have involved in our group and some of those relationships we've built along the way, but we've continued to find that we are very much better in numbers and sometimes find that there are a lot of great programs that were going on base individually through different organizations, but somewhat in an echo chamber where maybe that outreach was limited, or those other groups were not aware of programs that other teams had created. So we've really found it a great space for resource sharing, networking, community outreach. And this is going to include both on-post organizations, as well as off-post stakeholders as well. So as you can see here on the slide, we have a lot of stakeholders that we've brought into the group. So we have nutrition counterparts, myself and my lieutenant with me here at the MEDAC, but also our H2F or Health and Holistic Fitness nutrition counterparts that serve over with the brigades for soldiers specifically. We've got our population health nurses, Army Public Health Nursing, and then we started to really bring in some of our garrison groups as well. So that includes, here we have Soldier Family Readiness Division is the overarching division, and then underneath them, Falls Family Advocacy, our relocation readiness, financial readiness, and a few other programs under Army Community Services. And really some of these relationships were built when I first arrived up here in September 2022, just having such an interest in public health and community nutrition. For example, our family advocacy program has a few employees from Cornell Cooperative Extension, which has paid employees on base that participate in parenting classes, nutrition and cooking classes for spouses and family members. So I really had started to get plugged in with them when I was first up here and collaborating on some projects. And so that really helped when we formed this working group, that myself and Lisa had already built some connections with some of these groups on the installation. I'll also highlight a few here, again, more so with Cornell Cooperative Extension. So they have a few educators on posts, and we had worked with their leadership in their off-post locations as well. But we have worked on a number of nutrition initiatives for food security with them that I will outline. So we're very, very thankful for that partnership. And when it goes for all of these off-post entities, many of them had found out about our working group or our food resource guide that I'll share online or through word of mouth through some of their counterparts on base. And so really the word just started to spread. We also got the Food Bank of Central New York, located out of Syracuse, to have interest and get involved in our meetings. So a lot of great nonprofits off post where we continue to develop those resources. And I just like to mention that we did not solicit any of these groups to come and join us. That was an important piece along the way, especially with legal, as we got some of these initiatives started, is that these groups willingly came to us and often offered ideas as to how we could expand or create new resources. Also connected to our North Country WIC, great resource as they've presented before me. And I won't read all of these, but a lot of Garrison Command support and rapport that we've gotten along the way as well, just to make sure that any initiative that we had started got proper legal support, which was a consistent barrier or thing we had to keep working through for our projects. So one of our first projects that we started when we started this working group is that myself, Lisa, and my counterpart, Lieutenant Alicia Lee, wanted to create a food resource guide to really just encompass all possible food and financial resources to soldiers and their families. We were finding that there were a few lists of maybe a couple food pantries here and there from different organizations, but there was not one consolidated list. And each list that we looked at perhaps had some outdated links or phone numbers, which is very important to us, and we wanted to make sure that we could consistently update. So we scoured the interwebs and worked with our stakeholders to consolidate a list of both on-post financial and food resources, as well as off-post food pantries, soup kitchens, any federal assistance programs such as WIC, and nonprofits that were offering any classes or initiatives to help our families. So we created this starting in, I believe, spring of 2024 is when I had the first full resource guide going and up to date. And since we have tried to keep it updated quarterly, so that way we are skimming through, updating any phone numbers, point of contacts, locations, and removing any such programs that no longer exist. And we've really worked hard on the outreach of this resource guide. We've gotten it plugged in with our soldiers in processing through health and holistic fitness, so it's provided through those practitioners. We have our garrison organizations sharing this resource guide whenever they're doing any tabling events or our spouse connection events, even on the Facebook Fort Drum community and spouse pages as well. So we're really trying to spread it as far as we can. I created it through Canva and basically updated on there, but we did create a QR code that can be easily scanned, as the resource guide itself is consistently over 40 pages. And at the end of it has an index of program flyers for many of the resources listed throughout the guide. I should have put in an example of a few of the pages, but if you scan this in there or you want a PDF copy, you're welcome to reach out to me. And what was helpful as well is I did get plugged into the CR2C or the command quarterly council for resiliency. And so through that channel, I'll give some details on a brief that I provided to make sure our commanders were updated on the importance of this topic. But our division surgeon team and their sergeant major was able to send out an op-ord or operation order for units to be required to post this food resource guide in all of their spaces. So that was helpful as well, not only from the soldier sides and units to have it represented, but through our garrison channels as well. And so now I'll go into some of our initiatives or the successes that we've had. So our food resource guide, I'm able to look at the analytics through Canva to see how many views we've had. And these are unique views, not any individuals repeatedly looking at it, but there were over 980 unique views of the resource guide from March to December of 2024. And at this point, it is over that 1,000 mark, which is great to see. And so that in itself, we found as an accomplishment. We've really just had some barriers in being able to acquire the answers and the number of positive food security screenings within the MHS Genesis record. So we've been trying to keep metrics from our guide and all of these initiatives to continue showing the need for food security efforts. I was also able to brief at CR2C, which was to our garrison and brigade command teams back in September 2024. So at that point, we had only had a small amount of clinic metrics. We had about 32 nutrition referrals from March to September 2024, and 16 patients referred to the fruit and vegetable prescription program that I'll detail. Currently, we're at about maybe 3 to 4 monthly food security nutrition referrals, but I will be upfront that about 50% of those are still no-showing these appointments despite many efforts. We had a few metrics we provided from local food pantries where over 60 to 100 people per month were attending, just to really show that outside need to our commands to really help push and get some of these initiatives on post. So we also did a poll in our Facebook spouses and community pages in August 2024 and found a total of 215 respondents had answered, and with one question stating, in the past 3 months, I have worried my family won't have enough food. 23% answered yes to this, which was 50 respondents. I have applied for SNAP or other assistance programs, but I do not qualify. 38% answered yes to this, which was 81 respondents. And I'm not aware of local food resources, was 22% of the respondents, equating to 48 people. So we really just emphasized the need to our command teams, which helped us get some rapport in bringing some of these efforts on post. So I know I have just a minute or two here. I'm going to briefly go through some of the initiatives that we have successfully brought or started on post. So with Cornell Cooperative Extension, we were able to implement their fruit and vegetable prescription program. This originally started with medical referrals. So when our medical teams put in a nutrition referral for food security, they would be screened for us if they had any nutrition risk. This could have included things such as an overweight or obese BMI, something such as prediabetes, a vitamin deficiency, history of chronic disease, or other factors that would allow them to be referred to CCE for 6 weeks of nutrition workshops where they receive $25 in vouchers for fresh produce each week that they attend, which is a total of $150 in produce. On this, we worked with our commissary manager to sign them up as an available vendor for voucher redemption, which has been great, alongside off-post farmers markets and retail locations. So we're continuing to push that. And it has been expanded to include community referrals, so any health and wellness or social services programs, even our chaplains, our family advocacy program can now enroll participants or get them signed up for this. A really big thing we're very happy about is with our Community Action Planning Council off post. We initially started with an off-post Fort Drum dedicated site right outside the gate near our Luray Health Clinic, where monthly they were getting anywhere between 50 to 70 participants, which included families with multiple children. And then just starting this month, actually on the 17th, the third Monday of every month, we were able to go through legal channels and work with the garrison commander to get approval for them to come on post. And so I will be honest that was a very lengthy process, as not many other installations outside of a memorandum of understanding I had from Fort Irwin that we ran through our legal. But if there are any teams that have questions on how they could also get that started, I can provide more detail. I'll go over two other minor efforts here real quick. So we also have a thrift shop on Fort Drum where they offer very cheap or low cost clothing items and other necessities that has just started opening their own food pantry in December 2024. This is run solely through donations. They are themselves a nonprofit, a 501c3, and they're considering working with the Food Bank of Central New York here to expand to receive funding and food deliveries from the food bank. But as of now, February, March 2025, they've helped over 18 families each month, including 34 service members. Within those numbers, again, couples and or multiple family members included in there. And then I will say we're continuing to work with our chaplains and CAPC as well on chaplain emergency food bags, where our chaplains starting in April will be picking up food from CAPC's warehouse to be able to compile an emergency bag for those in need that will contain 5 days worth of food or 3 meals daily for those 5 days for one person. We're working through that. And both this mobile food pantry and the emergency food bags, how they'll be tracking this is through a New York State Emergency Food Assistance Program eligibility form that participants would fill out. And so I'll go to my next slide here, and this just, oops, I did go too far. This just kind of shows some of the flyers for those different initiatives. We've done some food drives together, and then we have the image of the fruit and vegetable prescription program on the right. And then way forward. So we just really are going to continue to work on our garrison involvement, staying in these higher level meetings, including that CR2C council, to report monthly metrics across the quarter for each of these initiatives, as we're really still in those early stages in getting metrics, continued outreach efforts and partnerships with these local nonprofits, and also just trying to expand the current hours as we see these initiatives grow. So for right now, that's all I have for today, but more than welcome to speak with any groups that have questions.
All right, this is Jeremy McCarty. I'm a PA at Fort Bragg. We've seen this food insecurity, or I've seen it through a lot of lenses as a junior enlisted soldier here 25 years ago, a non-commissioned officer with subordinate, young subordinates, a provider, and then since I joined the public health team about 9 years ago, I've seen this quite a bit. So the one key thing I think you should get out of all of this is look at these wins at these other locations. I won't go over some of the same stuff. We have very similar problems, but we've all kind of tackled it in our own unique ways. Some of it, I think, kind of double working processes. And so one of even the platforms that we're going to talk about, Miss Nelson, when she gets on, is just how we're trying to do that. How we get a quick win. How do you get something we're doing here and then make it yours somewhere else? Learning that in the Army. Anybody that's out there as militaries, you never write an op order from scratch. You always take somebody else's and try to just add to the work and improve on it. And that's what we're trying to do here. So we've had some of the same problems. You can go ahead, Whitney, on the next one. And we're tackling this, and we're going to talk for probably 10 minutes. We'll try to be brief. Not our strong suit, but we'll try to be brief. We're going to try to tackle, maybe one way that we did a little unique and different than the other two you've already heard. So our objectives is to gain insights from the unique demographics here at Fort Bragg. We call it the center of the universe. Explore how we utilize collaborative partnerships and how we've been able to kind of evolve the partnership that started, with tobacco cessation, and really moved into a whole public health partnership. Identify best practices and future directions. All right, so one of the unique things here is that we have a population of about 50,000 soldiers between Air Force, some Navy, public health, and then of course we have about 45,000 active duty service members here, and that's about 10% of the active duty population of Army everywhere in the world. So, that's a pretty significant thing here. But our public health department is also unique. Really goes to the fact that DHA really can't do a standardization because none of our locations are standardized resources with standardized populations and standardized missions. So we can share some of the same things like that Fort Campbell had or even Fort Drum, but we're not the same. They don't set us up the same. We don't get the same population or mission. And so each place has to kind of take what works for them and try to make it theirs. So our public health partnership, this is kind of a snapshot, started in about 2019 with UNC, and it was about tobacco. This is a tobacco state. We were looking at tobacco concerns with kids, concerns with military population, and we could talk and have a whole nother webinar about what we're doing with tobacco. But that partnership has evolved into a much larger thing. Between our accreditation, when we became accredited, and forming our community partners. And then this partnership, these were probably the two of the best things that's worked out for our public health department, through COVID and accreditation and having these partnerships and these relationships. And then with Chapel Hill and some of these other partners that we brought into other things, we've kind of found that getting through the red tape of bureaucracy, and someone had made a comment earlier, I think it was the first presentation where, it's a WIC is state funded. So how do you deal with that? And we've been able to utilize Cumberland County to help us with, the state portion of that. We've been utilized Chapel Hill with our research grants and some of the things that we're working on as being the lead. So then they control the money and we kind of avoid even taking the money into a federal system and then distributing it. So we found ways to make it work for us. And that's what's kind of unique. So again, take what you can from all these presentations and try to see how it works best for you and your community. Our strategy is, to conduct surveys, to try to see what the community is asking us to do. It's part of our responsibility to do community health assessments and then form the community health improvement plan under the guise of the installation commander, and try to do our best for the population that we serve. Pilot and implement evidence-based interventions. I've really drank the Kool-Aid about analytics and statistics. Everybody has stories. Everybody wants to talk about that one time. But when you get to funding and you get to reaching a general population that can make change, they want to see numbers. Like, where am I going to get my bang for my buck? Where are my resources going to go? Because everybody wants more money. Everybody wants more resources. So how do you provide that level of determination for them? Like, how do the analytics paint a picture so they don't really have a choice? Like, you got to do this. And that's what we're going to kind of get through with some of the WIC stuff. Hopefully we have a couple minutes to talk about. So someone has already went over this. They said about 25%. So MFAN had done, some of the Military Family Advisory Network and some of the surveys that were done showed that it was about 1 in 4. And then we did some community assessments and things here. Fort Bragg was actually 1 in 3. With the large population and the fact that some of our junior enlisted on this post can kind of get lost in the mix of all the different, large scale things that happen here, we found it's a little more widespread in this community. The utilization of WIC was a big one. I'll tell you that if we had more time, we could talk about some of the other great things that we've been able to kind of move forward with. Not only the council that we initiated that Ms. Nelson's going to talk about, but even taking the food insecurity and utilizing our wellness center to start taking that load off our family practice clinics, to start addressing this and some of the same things that the last presentation said, developing our own kind of book of all the resources available in this area and how to best utilize that. So 60% of eligible North Carolinians received WIC services in 21. This is information we got from our local partners at Cumberland County. 79% of eligible Fort Bragg families received WIC, and of 70% of Fort Bragg families using WIC wanted to assess WIC on post. It was something that was here, 20 years ago, and then through the moving and the growing, is that it got moved off post, and really kind of lost its favor for a while. And we really had to do our best to kind of re-energize that and even kind of get them back on post before we had a 100% permission. We kind of went for the forgiveness over permission route. Again, we could talk about at the end when we get to the questions. The survey respondents experienced food insecurity. 67% worry their food will run out. And again, this seems to be a common theme that we've already talked about. And 64%, at least sometimes, that food doesn't last long and they don't have the money to buy more. And that's even with some of the populations that we found, that didn't even, that couldn't apply for WIC or that weren't eligible. So that's why, again, we've kind of expanded this, but the partnership is the key that we're trying to drive home today. Here's a kind of a timeline before I turn it over to Ms. Nelson, is that, we did the surveys in 21. We started our partnership meeting and kind of evolving our tobacco into other public health things. We utilized some kind of space that we had for COVID contact tracing that was kind of robust, and public health was leading the charge. So we utilized some of that momentum and kind of brought them on post to building that we had through the Department of Public Works. And then we've relocated them to a better building inside one of our clinics. Actually has some pediatric stuff there, made it a lot more accessible to our people here on post. And then we've actually went through the real estate license and the fiasco of going through state funded entities on a federal installation. So we've kind of crack that nut, and I'd say we're at 99% solution there. It's already been signed and sent up to IMCOM, and we're almost at the finish line to make this a standard thing for at least the next 5 to 10 years. So because everybody else was long-winded, I'll try not to be, and I'll turn it over to Ms. Nelson, and we'll talk at the end. Thank you.
Thank you, Mr. McCarty. So yeah, I'm going to take us through the rest of the presentation. This work specifically for WIC was funded by the USDA and the Food and Nutrition Services to increase awareness, improve outreach, and boost WIC participation overall. So with our Cumberland County Public Health, like Mr. McCarty talked about with the funding stream, they were funded $204,000 for 18 months, and we're still within that period right now. Out of the 36 grantees, our partnership was the only one in North Carolina, and we were one of 2 projects that were selected to focus on military families as the priority population, with USU, the first presentation today, being the other one of those. So with this grant work, our goals, just like the grant was intended, were to raise awareness about the WIC programs within the Fort Bragg community, and this included doing outreach on the installation. With the grant funds, we hired a community outreach coordinator with Cumberland County, and so she went and talked to our MWRs, our family readiness groups, really in any in or out processing deployment brief that she could find her way into, and promoted these services, maternity fairs within the hospitals, had a lot of success with just her understanding of the program and being able to talk with families and kind of combat some barriers head on, one-on-one in person. We also coordinated to expand on our outreach efforts with the county, and even launched a multimedia campaign, which is currently running on podcasts, radios, commercials on TV, banners, with target audiences to show military families, service members in uniform, accessing WIC. And we also had lots of conversations, which I'll talk about, with our military families to learn more about the barriers that they have and how we can create best practices moving forward with combating those barriers and reducing our stigma overall. And then we also aligned with Military Family Advisory Network, who's an extremely valuable military support organization, to create the Military WIC Office Councils. And this council shares best practices across military installations. So here's a bit of a breakdown from our WIC data. This is from February 2023 to August 2024. So now currently we're well over close to the 9,000 mark as far as WIC enrollment. Out of the 4 WIC offices in Cumberland County, Fort Bragg being one of those WIC offices, we see 10% of all of the participants. And with that 10%, keep in mind too that we are only open 2 days per week on the installation. So we've been really successful. We've seen patients continue to come back. You can see these peaks towards the end here. These are recertification points. And so we can see those families that are continuing to recertify and come back to access those services. We've regularly surveyed the population. They really enjoy lots of different, from the nutrition education to the food benefits and lactation services, really everything about the office. And they're really learning a lot about WIC is more than just what they had initially thought. So we also conducted focus groups and learned more from the participants and provided them some incentive, again, through the grant funds, to kind of figure out this image focus advertising, what would work for them, what type of language would they like to hear in these advertisements, and how did they hear about WIC. And we also asked them lots of questions about their experience and why they keep coming back. Lots of these participants learned about WIC through word of mouth and just past experience with family members, and really successful overall with the focus groups. We had about 19 participants, but learned a lot from them. So I mentioned the Military WIC Office Council. This has been wildly successful, and it just shows that there's a true investment in all around in our other entities, whether they be military or local health departments, state health departments, that are interested in aligning efforts to combat food insecurity in the military overall. And so we've raised lots of awareness within this council. We've also talked about our outreach, our project that we've been working on, provided the council updates, and invited lots of other military support organizations and academic institutions, other military installations to present their continuous improvement work to increase outreach and access to WIC services. So at the last Military WIC Office Council last month, they're always hosted the first Wednesday of the month, and you're invited. If you'd like to join, just send me an email. At the last one, we discussed collaborating with partners and what types of partnerships that might be unique to maybe inspire and provoke thoughts from other military installations on who they might consider partnering with in their own community. And this upcoming Military WIC Office Council, we're going to talk about the logistics of opening a WIC on the installation, and then we have a few more lined up with really exciting projects from other places to again just inspire folks to not recreate the wheel and just try to see what can be copied forward to their installations. So what we noticed within our own evaluation of this program, and when we talk about health promotion and WIC, we're not just talking about telling the community members about WIC. We also have to tell our providers, nurses, healthcare personnel, our different groups on the installation that there is a WIC on the installation. We are constantly having to just provide that education and talk about the benefits and what they look like in the hopes that they have these interactions with the patients and can get them into the program. And so there is a hunger vital sign, which was mentioned earlier by Captain Whitbeck, and this is a great tool for us to have. But what happens when the provider selects yes to yes, my patient is food insecure, then what? So what we've done is created a pathway and leverage our Armed Forces Wellness Center, expanding their scope to involve food insecurity. If you're not familiar with the AFWCs, they already have a lot of, they have stress management, healthy nutrition education, and they also have the capacity at Fort Bragg, at least, to take on this workload of receiving these referrals and essentially becoming a clearinghouse, consulting for what families may be eligible for, whether that's WIC. We know that not every food insecure individual that's referred by the hospital, for example, will be eligible for WIC. So we wanted to make sure that we included food pantries, also the family advocacy programs, and financial readiness program. So there's a lot there and more to be explored, but we did just have all of this created within MHS Genesis for this referral system to go live, and we're there. And so now we're excited to kind of take those lessons learned and move forward with our food insecurity work and this system involved. So hopefully we can track these outcomes across all of these assets on Fort Bragg and continue to improve our outreach efforts overall. That is all I have. Thank you for your time.
Thanks, Ms. Nelson, and to all of our panelists today. This was great, inspirational work and great information to share with the audience today. We have had a number of questions come in from the audience, so I'll go ahead and start with those. I encourage those who are still with us today to put your questions in the chat pod if you have one, and we will get to as many as we can. The first question is for Benny and Dakota. When working with your WIC clinics, did they highlight something called a verification of certification that WIC can be picked up in any state with that document?
So I can take this one. We did talk with our clinics about the option of having the form for families to be able to transfer. The issue we were running into, it required the families to actually be the ones who asked for it. So if they didn't know that form existed, they would PCS and not ask for it. So there wasn't messaging currently in place that let them know that that was an option and something that they should be asking for near their last appointment at that clinic. So we're working on having some messaging, whether it's in our peds clinics, our women's health clinics, places like that, that's already talking about that, and then working with the local WIC clinics to also be informing families that this is an option.
Thanks, Dakota. And our next question is for Captain Whitbeck. Are service members and family members informed of and encouraged to go to the Family Readiness Center and utilize free financial counseling and budgeting services?
That's a great question. Yeah, I would say that they are often receiving that marketing and advertisement for those services. So that program for us is housed under our Soldier Family Readiness Division, many of which of those programs are in our working group, but we have many events, whether it's soldiers in processing, keys to connection, a spouse readiness or spouse connection group, things of that nature, where the families and or service members are provided this information consistently. But we did also add the financial readiness program into our resource guide as well.
Great. And Captain Whitbeck, while your mic is still on, I'll ask you another follow-up question. Is there guidance on the frequency that the food security screening should be completed? And then if a referral is made to a registered dietitian with a positive screen, are those appointments face-to-face or virtual?
Yeah, so frequency, we were advising all of the teams to do it at every encounter. I mean, I'll be upfront that we know they're not doing that. Our population health nurse, Lisa Prue, will often do chart audits for the nurses, and it's not happening in that manner. But we've just had limitations in enforcing that and pulling the metrics period for those questions answered. And then, forgive me, what was the second question?
So the second part of that question was when you provide a referral to a registered dietitian, are those appointments virtual or in person?
Oh, right. Yeah, we are having our medical scheduling assistant, our MSA, offer either. We know oftentimes that barrier is getting in for it. We do find that we prefer when it is in person, so we can actually physically give them the flyers and information on those programs and build that rapport with them. But we have done them virtual, and we're kind of playing around with that because we're seeing so many no-shows in person. We're trying to make them shorter phone calls at first and then sending them those resources as needed. But the Fort Bragg team brought up a great idea of utilizing the wellness center where it could be a lower threat place outside of the clinic where we could maybe shift that to.
Great, thank you. The next question is I'll open it up to all of the panelists. And Whitney and Jeremy, if you want to chime in first, that would be great. Who would be an ideal person to contact if my organization wants to initiate a food security partnership with a military installation?
Yeah, I mean, I wanted to add one thing before that Captain Whitbeck had said is that I don't know if she's tracking this because it kind of came about through secondhand. Is that when DHA pushed down that we were going to do food insecurity at every encounter, it has changed. It is no longer every encounter. It's once a year or if the situation changes. And so it really took some wind out of our sails. We were trying to get momentum with moving it to the wellness center as a kind of communication, loop back. So they've DHA has retracted with their new care models that they're pushing out. That it's no longer, it's just once a year. But to go to your question, DHA has a hard time standardizing things, like I said before, so it's hard to give a standardized answer. So based on your location, that's what you have to determine what your partnerships are going to be. We had a great partnership with Cumberland County through accreditation, and so bringing them back on post became a wonderful idea that worked for us. And through our MWalk, we've noticed that that's not going to work for every population. When they have a small population, or we've had people in the MWalk tell us that their community is just you know they're flooded with requests in the community, and it's a state, each state has their own state funded WIC, and there's some minor differences. So depending on your insecurities, you really got to look at who your partners are in your area, and then someone needs to do that reach out of like, hey, let's start a council. Nobody wants to be part of it. At the beginning, there's a couple good idea fairies that just kind of throw stuff out there, magical, but someone has to just take that on as a workload, and then we try our best to make sure that we keep it as valuable as possible to as many people as possible, so we don't lose the momentum. Not oversharing ideas, not having too many meetings, making sure that we at least try to get information from people and change it up and keep them coming back, if that helps. Over.
It, Captain Whitbeck or Dakota or Benny, do any of you have a different perspective for that question?
Yeah, I'll add a couple points. I mean, I would agree with what Mr. McCarty said is it definitely will depend on the installation, but for example, here, like if you just find one point of contact, whether it's a Department of Public Health or the nutrition clinic on the post in their website, or even some of the soldier readiness programs like family advocacy, maybe finding one email or phone number and reaching out to them, asking if they have something going already. Because I think here, that's what we found is many of these off-post entities never knew like how to get in touch with someone on post or how that could even work or if it was allowed. But they found my contact just specifically because we had this food resource guide out, and then the conversation started. So they might have had ideas years ago and they just weren't able to find a good point of contact. But if that person you contact doesn't have anything or doesn't know, then maybe initiating the idea of starting something.
Great. Benny or Dakota, do you have anything to add about contacts to develop partnerships for food security work?
Yeah, I think I'll just echo what we said during our presentation and what others have been saying. I think just making connections with with the base leadership and helping them recognize that these are concerns, and that it's not that anybody's doing anything wrong. It's just the reality that there's food insecurity, that the DHA is recommending focus on food insecurity, and how can we all work together to meet the needs of military families. That is what helped us be successful.
Great, thank you. So a few of you alluded in your presentation to some funding mechanisms for part of your work, but I wonder if any of you would elaborate if there were any additional funding mechanisms or any funding at all that you accessed or utilized for the projects that you started.
I think we talked about here at Bragg that we started off with a partnership, and then the UNC was really big on research and grant projects. So helping us, we've kind of have a robust one now where we've got 5, 6, 7 in the works and 4 that we're doing. It's brought in millions of dollars for our community projects that we've used. We've used it for training our providers for tobacco cessation. We've used it to get people that have part-time jobs here that are 100% focused on how do combat military food insecurity here on Fort Bragg. I mean, even the person that's our coordinator with the local WIC office. So I'd say it's a great way to get in partnership to get some of these grants because as everybody knows who watches the news that our funding is up and down and depending on CRs, and they really lump public health for us. They lump our all of our wide variety of things in the same funding mechanism. So it becomes an issue. Over.
I'll go ahead and speak then as well. So up here at Fort Drum, we started and continued. We don't have any funding sources. Our public health team here is small, comprised of a few Army public health nurses and epidemiology tech. And our department, they are not accredited yet, so we haven't had that opportunity to form those larger partnerships. So we have really just been leaning into those nonprofits, whether on or off post, and any funding sources they are able to utilize for the initiatives that we've tapped into. Over.
Yeah, and this is Benny Choxy just responding on behalf of Dakota and myself that we have had university support in terms of a small amount of intramural funding, but what really helped us get this off the ground was a WIC Chow grant and subaward, and I can put that funding mechanism in the chat, which I know several on the call are familiar with.
Thanks, Benny. That would be great if you could put that information in the chat. So all of the presentations and a lot of your answers today have talked about partnerships, both on the installation and off the installation, and some of the benefits and also the challenges of developing those partnerships. Can you all speak to maybe your biggest challenge or maybe a nice surprise that came from those partnerships for you?
So through the partnership and the public health partnership, at this point, it's very well oiled and matured over time. I do think that we can't voice enough for how beneficial this has been. And we're constantly surprised at how much we can accomplish as a group. And with accreditation and now applying for reaccreditation, and we were the second ever military installation at Fort Bragg to become accredited in the public health department. We have realized how we can really gear both our goals and the community health assessment needs through evidence-based data analysis, which would only be made possible by this additional manpower that we have, both by, like Mr. McCarty alluded to, these funding sources of additional part-time personnel that work through the county, but also our formalized student practicum program. We wouldn't have been able to present today without the work and data analysis, the surveys, the focus groups that were all coordinated by the students in the military research team at the University of North Carolina. So I can't emphasize enough having those conversations and also reaching out to your public health departments, because chances are they are directed to become accredited and partnerships are part of that. But in smaller installations, Air Force bases, sometimes that is more of the dietitians and nutritionists. But I agree with what Captain Whitbeck said. Just find one person to talk to and see if you can, in a group email box, and see if you can start a conversation, find out where they are, and see how you can expand on those efforts. A lot can happen from these partnerships, and the great work that we have done is in large part to the efforts of us, but and huge thanks to our partners.
I'll comment as well. I think our biggest barriers up here, myself and Lisa, my co-lead, is that, well, first and foremost, this project, this working group and efforts are not our primary job, right? I'm still in the clinic seeing patients full-time throughout the week. So trying to find time on my admin time to still reach out to other groups and do the behind the scenes work, for example, with our mobile food pantry. And then just kind of, for example, with that mobile food pantry, bringing it on post and being really patient with government systems and working with our legal. That was a thought over a year ago, and we've just now got it on post and approved. So really being persistent has been a challenge, but a rewarding one. Over.
As far as partnerships at Campbell, I think one thing to consider is meeting with everybody and taking into consideration all the people who will be affected by a program you start. So, like when we started, we contacted at the state level for the WIC clinics. And while, those people are involved, we should have engaged more with the staff, the local clinics, because when you get down to it, it's their workload that's increased. They're the ones seeing the families. So engaging them more and not so much at the highest level, but also letting that trickle down and allow them to have a say in, how the messaging, how the flow will work and stuff like that. Because we received a lot of pushback in the beginning. There was concerns of, we've got too many patients coming in, the waits for appointments is getting long, what do we do now? So we had to really kind of step back and then try to reestablish and build that relationship. And another is, especially if you're working with specific groups of people. So we take military families as an example in this situation. It can be kind of a closed system. And so if you are not engaging and building the support within that community, they may not want to reach out to you as much. So it's helpful to hear the voices of the people you're actually working with, allowing them to help you build the program. It helped me because, I'm a military spouse. I was on WIC, so I could sit with families. I could relate. They didn't feel judged. They didn't feel like I was telling them. They just didn't know how to manage their money. And that's really helpful in building those relationships, even down to the family level and clinic levels.
Yeah, this is Mr. McCarty. The last thing I would add is I ditto everything everybody said, is that the partnership has to be both ways. So, looking at when we got WIC on post, it was finding out what Spring Lake in the Spring Lake office in Cumberland County needed and understanding how their funding goes. That their funding is two parts. Their funding was based on enrollment and they get money allocated, but if they don't have the participation, they can actually take money away from them. So making sure that even the movements that we had on post and the access we've had on post, because we had our trials, is to make sure that they still had their numbers because they're the ones paying the salaries of them in Spring Lake. So it's been a great partnership because we've tried to make sure that we've helped them in many ways. Same thing with UNC, with UNC bending over backwards to assist us and evolving that kind of tobacco relationship to food insecurity and other projects. We've also tried to open up for their students to do their practicums here. And, the analytics that they do for us, they get credit for that as well. So making sure that partnership has, positives on all sides. Over.
Thank you to all of our panelists today for this insightful Q&A and also the great valuable information that you provided in your presentations. And thank you to all the participants who have asked the questions today and kept this important conversation going. We really appreciate your collaboration. For the sake of time, I'm going to go ahead and get into future webinars and continuing education information. If there are additional questions, we have a few minutes and the panelists could engage in the chat with participants if there are, but I'll go ahead and invite you all to our next webinar, which will be on April 29th at 11 a.m. Eastern, titled Energy Drinks, Dietary Supplements, and Operation Supplement Safety, presented by Ms. Andrea Lindsay. And this webinar is the first in the Nutrition for the Tactical Athlete series. Many service members choose to consume dietary supplements to improve physical performance, build muscle, lose weight, enhance cognitive function, boost energy, and more. But unfortunately, some dietary supplements can compromise rather than improve performance through the production of adverse events and positive drug tests. This presentation will highlight tools and resources available from Operation Supplement Safety, the Defense Department's established program of record for anything related to health, wellness, and performance products to help service members and general consumers make informed choices about dietary supplements and energy drinks. And we will post the registration link for this webinar in the chat pod. We also invite you to join in the next 3 webinars in the Nutrition for the Tactical Athlete webinar series. Tactical athletes are military personnel, police, firefighters, and first responders, and the Defense Department alone has over 2 million active duty and reserve component members who are all considered tactical athletes. These professionals have unique health and nutrition needs. Following the Operation Supplement Safety webinar in April, there will be 3 additional webinars held in May, June, and July, covering the social drivers of health for the tactical athlete, special operations nutrition optimization, and engineering food to fuel warfighter performance. Attend these webinars in this series to learn how the Defense Department meets tactical athletes' nutrition needs in the environments in which they serve, and develop your skill set for supporting the nutrition needs of tactical athletes. And in the chat pod, we've shared the link to this series. For today's webinar, 1.5 continuing education credits are available from all the credentialing agencies that you see listed on this slide. A link to the webinar evaluation and to receive your continuing education certificate is being placed in the chat. You may also visit the webinar event page to obtain your certificate. On the event page, you will find the purple continuing education link. After completing the evaluation, you will be directed to select the appropriate CE opportunity, complete a post-test, and fill in your name and email. Your certificate will be emailed to you. Please note that some email addresses will direct the certificate to the spam folder, so please check there if you do not receive your certificate. If you have any questions, please contact us at the email listed on the slide, ce@oneop.org. And as a reminder, a recording of today's webinar will be archived within 48 hours to our YouTube channel, which you can access via the event page. And be sure to visit us at our website, oneop.org, to explore upcoming events, articles, resources, and more. You can also find us on Facebook, LinkedIn, and YouTube. We will stick around for a few more minutes for those who might still need to grab links or information from the chat. But thank you all again for attending today. Thank you to the panelists for the wonderful information, and we hope that we'll see you at the next webinar in April.